So hey everyone, I'm excited to sit down with Dr. Norm Robillard and just talk about, is there an alternative option to using antibiotics if you have SIBO or IBS? And also kind of just learn from his knowledge as a microbiologist and as a researcher in this field. So just a little quick bio on Norm Robillard. So Norm received his PhD in microbiology from the University of Massachusetts, Amherst, studying Bacillus anthracis and other Bacillus species. His postdoctoral training at Tufts University focused on antibiotic resistance and gene transfer between the gut microbes and Bacteroides fragilis and E. coli. During his career in pharma and biotech, Dr. Robillard studied the genetics of antibiotic resistance, septic shock, viral illnesses, and antimicrobial and antibody-based therapies prior to founding the Digestive Health Institute. So now he has an awesome website. You can go and check it out at digestivehealthinstitute.org. He has all of his good content and resources on there. And he's just a wealth of knowledge. That's why I'm so excited to be able to sit down and chat with him about, his thoughts and his take on, what you can do if you have IBS or SIBO and what you can do from his understanding of microbiology as well. So awesome. Thanks for joining me, Dr. Robillard. And even though I did a little bio, if you could just give us a quick intro of yourself and maybe why you got into this field and, so.
Sure. Yeah, I appreciate that. And thanks, Josh, for having me on. I am a microbiologist. That's what my studies were in. Yeah, Bacillus anthracis, anthrax, kind of a nasty pathogen, but I also studied a lot of gut microbes. I live here in Watertown, Massachusetts, which is just outside of Boston. And when I'm not reading studies or working with clients or working on some projects, like we're updating our Fast Track Diet mobile app at the moment, so that's been a bit of a workout.
Yeah.
When I'm not doing those things, I do have a few hobbies. I keep an organic garden, and I like to compost. So a compost pile and a great garden that's really producing a lot this time of year.
Yeah.
What else? I like to travel and do carpentry, mostly home improvement stuff. So I'm keeping pretty busy.
Yeah.
As far as how I got into digestive health, I'm not going to tell the long version of that story. I've told that enough. But it's funny, my story reminds me of your story a little bit and your journey with IBS, although you recognized and did something about it at an earlier age. In my case, I had some IBS symptoms, but they were more chronic acid reflux symptoms, and I had this probably from my mid-30s to almost my mid-40s.
Okay.
It may have been over a decade of having this chronic struggle, including a terrible heartburn, regurgitation, aspiration reflux. I mean, I was miserable, and here I am, working in the field, and I was in the biotech industry. I was actually working on antibiotics and some of the other things you mentioned. But the drugs my own industry had to offer, PPIs, proton pump inhibitors, and H2 blockers, they helped my symptoms a little bit, but I could still feel I had a problem.
Yeah.
But that all changed about, it's like 14 years ago now. So it was a while ago when I went on a very low carbohydrate diet with one of my sons, who was an athletic trainer, and my reflux symptoms literally went away.
Yeah.
And I just got so curious about why. There'd been a couple of studies on it. People were saying the same thing, but why would carbs cause reflux? So I started doing a lot of research on that and how are these foods digested. And when I got to the intestines, that's when my microbiology background kicked in. And I thought, wait a minute. What if I'm not absorbing all of these carbohydrates I'm consuming? And I was on a high-carb diet back in those days. If some of those are feeding blooms of gas-producing bacteria. And at this point, I had never even heard of SIBO.
Yeah.
But I was thinking, it's excess fermentation and gas pressure building up and driving my reflux. So it was a completely new way of looking at this old problem compared to the 60-year-old theory about the dysfunctioning of these lower esophageal sphincter muscles.
Yeah.
So it's a new theory. I've written a couple of books on it. There's a lot of evidence supporting it. But more importantly, in terms of my career, it really opened my eyes to the power of diet. Before that, I was thinking, diet, what is diet going to do? I never really paid it much mind. I was really in the drug industry.
Yeah.
And but it opened my eyes, and I realized the connection between IBS, acid reflux, right, that 50% overlap, all of these other functional GI disorders, and as well as fibromyalgia and rosacea, chronic fatigue and autoimmune, all of these connections, and it all tied in. So I decided to just change my field, and I started the Digestive Health Institute, and that's what I've been doing ever since. So
that's awesome. Yeah, what a cool story. It's it's so interesting when you come down with symptoms and issues like that. You just become so curious about why it's happening. And it's cool that, like, this was probably even before the term SIBO was around when you started having these issues and started diving into, thinking about microbes, right, in that equation. Yeah.
Right. I mean, it was, there were, some people might have used the term SIBO, but small SBBO, small bowel bacterial overgrowth, was a common term, and it was mostly associated with surgical procedures that left blind loops in the intestines, and surgeons soon learned they shouldn't do that. So that's where it started. But really, when you trace back carbohydrate intolerance in general, even like lactose intolerance or fructose intolerance, that is what is happening, is you're feeding these bacteria either in your small intestine and even the early part of your large intestine, and you're getting too much activity and too much gas.
Yeah, definitely. So we'll get more into kind of, some of what you know about antibiotics, and kind of, you talked a little bit about the pharmaceuticals. You have a background, working for biotech companies, and, you're familiar with kind of some of the side effects of using those things as well. So we'll get into that in a little bit, but I guess let's just start. I want to focus, like I said, in this interview on, treating and managing SIBO without antibiotics. So my first question is like, is this possible? So, what are someone's options if they don't want to use antibiotics to treat SIBO? Because right now, that is one of the main treatments. And, there's been studies that showing it works very effectively, but it's always about kind of the risks versus the benefits and the long-term thinking too, right? So what are someone's options, and is this possible to go with that?
Yeah, it's a great question. There is a prevailing idea out there that it's not possible to treat SIBO in these conditions without antibiotics.
Yeah.
But really, I think you can just as easily ask that question in the reverse and say, is it possible to treat SIBO in these conditions with antibiotics if you don't change your diet?
Yeah.
So while I answer your question, you can ponder that one.
Yeah.
Because I think it is possible to treat SIBO and these functional GI conditions that are related with a diet. But there's a caveat there. It's not just diet. For instance, and by the way, I'm not against antibiotics for very serious cases of SIBO where there's, malnutrition or, severe underweight or can't digest any fats, steatorrhea, bone fractures because you don't absorb all the minerals correctly. There's a lot of conditions, and SIBO can get worse and become more serious. So I'm not saying that antibiotics can't play a role, but I just think that science-based diets and behavioral strategies, as they evolve, they should replace antibiotics as the first line of therapy. And right now it's the reverse, and I just don't agree with that. So what are the options? Well, one thing I can speak for is the way that I've designed the fast-track diet.
Yeah.
So the strategy that's in these fast-track digestion books is one on heartburn, one on IBS. The same strategy that's in the Fast Track Diet mobile app, and the same strategy that I use in my consultation program depends on three things, right? And the first one is all about diet and hard to digest carbohydrates and malabsorption, and using this FP calculation I created that quantitatively measures 5 types of carbohydrates: fructose, lactose, resistant starch, fiber, and sugar alcohols.
Yeah.
The same 5 carbohydrates that you'll find if you look it up in the textbook of primary and acute care medicine in the chapter on intestinal gases. It will say the exact same thing. If you don't want too much intestinal gas, right, and we know that's at the center of this problem, hydrogen and methane, hydrogen sulfide, you need to limit these 5 types of carbohydrates. So that's what this FP calculation does. The first part of the diet is to, at least at the front end, really get this fermentable material quantitatively under control.
Definitely.
But there are 2 other parts in the book.
Yeah.
And one is identifying and addressing potential underlying or contributing causes. Mm-hmm. And there's a chapter in each of the books and in the app on this very thing. But it's an active area of research, so people might need to get a little bit of help to work through those. And most of those won't apply to each individual case. It will just be 1 or 2 of them. The rest, you can get rid of it, but you need to do that in a systematic way, and you can do that based on the risk factor approach.
Yeah.
For instance, a lot of people I work with, as soon as they come to me, they're like, "Oh yeah, I have low stomach acid." Mm-hmm. I'm like, "Okay, how do you know that?" Well, I did the baking soda test or something, which is not really a valid way to determine that. Yeah. But you can very quickly determine if somebody has low stomach acid or not by looking at key risk factors. Here's the risk factors for low stomach acid. Are you taking PPIs or H2 blockers? That's what they do. Mm-hmm. Okay, not taking those? All right, take it off the table. Yeah. Have you been diagnosed with H. pylori? Because if you have a prolonged H. pylori infection, it could lead to atrophic gastritis, and it can really damage your stomach and lead to low stomach acid. Yeah. Been tested negative? Take it off the table. Do you abuse non-steroidal anti-inflammatories? Drugs, pain drugs, maybe you have arthritis or a sports injury and you take those all the time. Well, those can damage your stomach and cause the same thing. If you don't have one of those 3 things, chances are your stomach acid is completely normal. Yeah. And that's been shown with a lot of studies of people with GERD. Most of them have normal stomach acid. Some, there is a subset that don't. The only other factor that could lead to low stomach acid, well, cancer and so forth, some more extreme things. But there is an autoimmune version of atrophic gastritis, but it's quite rare unless somebody has Hashimoto's or another autoimmune condition. So working through these underlying causes is really a big part of this approach. And then the last one that unfortunately goes under-recognized a lot, and that's behaviors and practices that optimize digestion, but also minimize malabsorption. And, you've heard about eat your food slowly and chew well. Well, there's really some scientific reasons for that. How much amylase do you have in your saliva? It varies person to person because the gene copy number people have for amylase varies. So, but there's more. How are you selecting your foods? How are you preparing them, storing them? Yeah. How, the whole resistant starch thing, refrigerating them, and also how are you consuming them? Yeah. So those are the 3 parts that I focus on.
Yeah, that's very interesting, and I kind of like the last point you made about diet too. Is that it's almost like we've kind of lost our roots to like how we make organic food and sit down and enjoy a meal and take our time, and there's a lot of things we've kind of gotten away from with the way the world is moving and the speed of the world. So it's so important. And also the idea that, diet for a lot of people, right, could be a really, really good first line treatment. And then always cases where antibiotics will be needed. Like I've taken them as well and they've been helpful, but I agree with you. I think it's one of those things where it should be like the last step on the treatment ladder, right? If someone's really not getting better and they have a severe case, then maybe antibiotics are needed. But starting with diet and those other fundamentals, I think for a lot of people can be a really good strategy.
Sure, I would agree with that.
Yeah. Do you see pretty good success helping people manage and treat functional gut disorders like IBS and SIBO, with your diet approach and without using antibiotics?
I do. Yeah. I see it every day in my consulting practice. Reviews on Amazon for our books, reviews on the Google and iTunes sites for the mobile app. Yeah. Feedback from people on our Fast Track Diet official Facebook group. We have 8,500 people there. But, more important than my self-testimonials, I think, are the studies. There are a lot of studies that go back, decades on the validity of limiting carbohydrates. whether it's low-carb dieting. Look at the work of the guys from Duke, and even some of the guys left Duke did some additional studies. The FODMAP, there's a wealth of FODMAP studies out there. There's great studies just on eliminating fiber, just taking fiber out of the diet, like Professor Hunter in UK over a decade ago did the study where he eliminated fiber. He had people in those chambers that measured gas coming out of every end of you, and he found that just eliminating fiber reduced intestinal gases and improved, these are IBS subjects, improved symptoms just as well as metronidazole, flagyl, a very powerful antibiotic. And these diets go back a long time. Lactose intolerance has been known about for over 100 years, and it's a durable response when you stop taking lactose. If you have lactose intolerance, they've done studies where they've looked 5 years out. Still avoiding lactose? Yes. Have any symptoms? No. Same with fructose. Been studies on fructose. So there's when you really go back and look at the literature, I mean, these problems used to be considered carbohydrate intolerance, and somehow we got away from that when we started. Oh, it's bacteria. We can kill the bacteria. But really, they were diseases of carbohydrate intolerance, recognized as that for a long time. So I think it is a valid approach. We have to continue to keep making the approach better. Keep evolving it.
Exactly, because the more options we have besides using antibiotics, the better, in my opinion. If you can use something else that doesn't have the side effects and it works effectively, that's awesome. So from your knowledge of, the microbiome, microbiology, what are kind of the pros and cons if someone's considering using antibiotics to treat SIBO? What do they need to be aware of?
Sure. And there are some pros. I mean, we talked about when there's more serious SIBO-related condition, extreme weight loss, and other things. So there are times when it may be a good choice, and it's good to talk to your doctor about it. Another pro is they're fast and easy. Feel good. Pop a pill. I think people really like that part. You don't have to really do anything extra, like, I need to change my diet. I'm a foodie. There's a lot of people. I'm a foodie too. But you might need to change your diet as you get a little bit older, especially your digestion may not work quite as well. So, but it's easy. Also, there's a combination of neomycin and rifaximin that is pretty effective for knocking down the archaea and reducing methane. So constipation can be a very challenging condition for some people. There are a lot of strategies and a lot of things you can do. And I work with people on this before you have to do that, but I do think that's an opportunity sometimes where antibiotics are used. But of course, as you alluded to, there are a number of cons with antibiotics too. One of which is the efficacy. How many people will they help? Not everybody, but a lot of times people do see an initial improvement in the symptoms when they take an antibiotic. One of the big drawbacks of, and this gets to the question I asked before, can you solve this if you go on antibiotics, but you don't change your diet? I don't think you can. And the evidence is in the durability studies of these antibiotics. And just as an example, there were these studies called Target that were used to register rifaximin with the FDA to get approval to treat IBS-D. Target 1, 2, and 3 studies. The Target 3 studies, the FDA wanted more information on retreatment. What happens when somebody, fails the therapy and they need to be retreated? Will it be as efficacious? And so in that study, they did look at people that had responded initially, and 10 weeks out, just over 2 months, 50% of those people had relapsed. And when they looked 20 weeks out, and I'm not citing this from the Target 3 study directly, but I believe it's correct from the source I used. But when they looked 20 weeks out, they found that 90% no longer were responding. Their symptoms had come back. So the durability is an important point. And as I mentioned, carbohydrate restriction is durable. It is durable as long as you do it. There's no resistance. So that's a difference between the two. The other concerns with me concerning antibiotics, and like everybody, I've had to take them myself. I had Lyme disease 2 years ago. I had gone hiking in New Hampshire. 4 days later, I collapsed on the couch with a terrible flu, and we found a Lyme tick right in the middle of my back.
Oh, wow.
It had been there for 4 days, and so I had to go on doxycycline. I didn't want to stay with having Lyme disease, but it was terrible in my gut.
Yeah.
So sometimes we have to do it. But here's one of my other concerns: is resistance, antibiotic resistance. And I know with these non-absorbable antibiotics, they talk about, well, the resistance is lower, it stays in your intestines. But, there is a fecal oral route of perpetuating resistance. And antibiotic resistance is such a huge problem right now. Some 250 and maybe 500,000 or more people a year in the U.S. alone are infected with antibiotic-resistant bacteria, and 23 to 25,000 of them die every year. So this affects all of us, and so the judicious use of antibiotics is so important. And you might throw in the risk of Clostridia difficile infection. I was just working with somebody last week that had been on antibiotics, came down with C. diff, didn't even know she had it, but I recommended she get tested because she had the symptoms, chronic diarrhea. I got tested. They put her on a bunch of new antibiotics, which I couldn't believe. When she talked to me, I said, wow, fecal microbiota transplantation is the way to treat this now. Why are they still using antibiotics?
Yeah.
She got an FMT from a wonderful doctor the next week, and she's absolutely fine.
Yeah.
But it is a risk factor. So something to keep in mind.
Yeah, definitely. And really important that, you talked about, the relapse rates, right? Because I think a lot of, I listen to a lot of the lectures and a lot of the latest talks from doctors and stuff, and you rarely hear the doctors talk about the relapse rates, which is something I think as a patient, when you're considering antibiotics, like we talked about, there are cases where they're necessary, right? And some people have pretty severe condition and it may be a good option for them. But I think it's really important to just keep in mind, like you said, that, a majority of people are going to have a high potential to relapse after 3 months, right? You were saying 90% after however many weeks. And
that was one situation, but what you're really saying is we need longer term studies, and we just don't have them.
Yeah, there's a need for longer term studies, and also, like you're talking about diet, diet is for sure a way for a more consistent long-term treatment approach as well. So that's why it's such a cool option for people to use.
It needs to be part of the equation. There's just no doubt in my mind.
Yeah.
15 years later, after it worked for me, it's still working, and it's working with all the people that I talk to.
Yeah, definitely. So
if they're willing to change the diet.
Yeah. Yeah. So just to wrap up this little discussion, so without antibiotics, the main focus to help restore more normal digestion and gut motility. So it mainly diet and mainly other lifestyle type factors that go into, taking time to eat, the food you get, the way, all those things. Is that kind of conclusion with that?
I think so, but your question's a good one, but there's more than just digestion and motility. There's a lot of these underlying causes. There's 25 or 30 I could just think of offhand.
Yeah.
And so that second part of the program that I talked to you about, ruling out most, but identifying and addressing certain underlying causes is really critical.
Yeah.
We talked about that woman I worked with that ended up having C. diff and finally FMT caused it. But here's a couple of other ones that show, there's all kinds of things that could go wrong. I worked with a woman who had SIBO, was very sick, but when I work with somebody, I start off with 45 minutes or an hour up front and really get their story and really listen, because there's a lot in that story. And this woman just casually mentioned that in the 90s, she had been diagnosed with hepatitis C.
Okay. Yeah.
And immediately I'm like, okay, stop. Let's really. And she said, oh, you don't have to worry about it. I took herbs to treat it. I'm like, well, okay. Have you been tested since? And she's like, I don't need to. I'm still taking the same herbs. 20 years later, she's taking the herbs.
Yeah.
And so I said, well, I think, since this a virus can be quiet for 10 or 20 years, and then it can damage your liver and cause not only liver cancer and hepatitis, but lots of digestive problems as well. I think you should get tested. And there's now drugs with a 95 or 96% cure rate for hepatitis C. They're expensive, but I think she should get tested. She was tested, she had it, and luckily her insurance paid for it, and she made a remarkable recovery.
Wow.
But it's not one of the more typical things you think about with SIBO, but just by hearing the story. You also, a common term out there that I think is getting thrown around recently is, well, you might have adhesions, right? When you had surgery or, different organelles or organs, your pieces of your intestine can stick to organs or your stomach, your abdominal wall and so forth, and they get kind of kinked and don't work that well. So it's one thing to talk about that, but I was working with a guy that had chronic diarrhea for 20 years.
Yeah.
Could never figure out what caused it. And like a lot of other people, I was like, okay, well, you're SIBO positive, that can be a cause. But hearing his story, he mentioned that around 20 years earlier, he had surgery for hernia repair. And I said, well, there is a possibility of adhesions. And in his case, he was lucky because he was going back for another surgery on something completely different. But when a surgeon was in there, he examined the spot of the prior surgery, found multiple adhesions, corrected them, and he made a complete recovery. So again, it just goes to show how important that middle piece is.
Yeah.
But yes, definitely fermenting the carbohydrate, limiting the fermentation of the carbohydrates is an important one as well. Focusing on the pro-digestion strategies.
Yeah.
But there's a couple of other things we haven't talked about. One is drugs. First of all, just evaluating the drugs and medicines you're on, because you mentioned motility. A lot of drugs have a side effect with diarrhea. Side effect of diarrhea or constipation. So looking at the drugs you're taking, you may need to reduce the dose or change medicines. Another big one, weaning off proton pump inhibitors or H2 blockers. It's huge. And a lot of people think, okay, I've changed my diet a little bit. Maybe I don't need them. People with LPR, they don't help anyway, so I can get off them. But it's not just a question of, oh, I can get off them. I don't need them, so I'll get off them. It's more a question of you need to get off them as part of the solution because you need your stomach acid for a whole lot of reasons we could go into. Another big one, people don't realize, non-steroidal anti-inflammatories. They're over-the-counter. People, take them like candy now. Every neck pain or back pain or sports injury or arthritis. And I understand we don't want to be in pain, but there's not just the risk of gastritis and ulceration from these. It's now recognized there might be a more serious issue called NSAID enteropathy, where these drugs literally cause little tears in your small intestine, leaky gut, inflammation, and it may be a more serious condition than the gastritis and ulcers. So, and it has to do with recycling these NSAIDs through the liver and back with the bile over and over again over the intestines. So that's huge. And then one last one, of course, dietary supplements. A lot of people have deficiencies and can really be helped with digestive enzymes that, again, improve digestion and minimize malabsorption.
Yeah.
So there's a few things.
Yeah, awesome. And, so the bottom line is people need to remember that SIBO happens because of an issue, right? So get checked for all the underlying causes. Try and work through those things, right? Look at the health history, all those things. And then, so awesome points there. So let's kind of talk a little bit more about what is kind of the best way to build a healthy gut over the long term for people with IBS and SIBO. And I know this is tricky because a lot of times with diet, right, if you have bacterial overgrowth or IBS, like you said, like you hit on before, too much fiber, too much fermentation causes a lot of problems. So how do you balance that with, there's a lot of people out there saying that a diverse diet is the best for the microbiome. First off, do you usually recommend to stay on the lower fermentation or the fast track diet for the long term, or just a certain amount of time?
Yeah. That's a great question, and I do believe in a diverse diet, and we actually have a diversity protocol that we use to help people diversify their diet. But on the front end, you really do need to restrict these fermentable carbs. And using this FP calculation, It's a mathematical formula based on the glycemic index that quantitates the fermentable carbs, the ones that stay behind in the intestines, as opposed to the ones that enter the bloodstream. Using the FP calculation really cut back on those initially. And the reason why is just look at how much gas bacteria can make from unabsorbed carbohydrates. 30 grams of unabsorbed carbs, that's just a little over 1 ounce, can allow gut bacteria to produce 10 liters of gas. So it doesn't take much. And when I explain that to people, they realize, oh, wow, I didn't think I was consuming that many. But a typical diet has about 150 of these FP points, whereas we recommend people really think about the 20 to 30 range early on. And we're getting educated by our own people on the Facebook group. There's a lot of people with LPR, laryngopharyngeal reflux, very tough condition to treat, that are telling us that, you know what, I didn't start really feeling better until I went down to 15 points. And now it's starting to work. So we're listening to them and thinking for some conditions, you might have to really restrict the points on the front end. How long? I think one of the mistakes a lot of people make is the foodies especially. They want to be cured, and they want to get back on the diet. And so, well, I've done this for 2 weeks, and now I need to go back to my regular diet. I'm starving my microbiota, which is just not true. These bacteria evolved in our intestines, just like all other animals on the planet. Evolved in our intestines. Yes, they help train the immune response. Yes, they help modulate and manage fat digestion, and they make vitamins, and they protect us against pathogens. But the main reason we evolved with these was to salvage calories when we're starving. So they saved us from starvation. So even though we've beat up our microbes over recent years, they're still, I think, quite robust, and I don't think you need to worry about starving them unless you go to the real extreme, anorexia or something like that. Because your mucus also feeds these bacteria. So I do think you have to be strict on the front end, do the underlying causes piece, do the behavioral piece, and then when your symptoms are better, that is an indication that there's less of this bacteria in your small intestine. And don't forget, when you have SIBO bacteria there, they're producing enzymes like proteases, they're scavenging nitrogen. And when they see the little enzymes being produced at the tips of your microvilli, there's bacteria there, and those little proteases there, they'll digest them. And there go your enzymes, and now you can't digest sugar or starch. So you need to wait for your symptoms to improve, and then only gradually start. You can start diversifying your diet. You can start adding more FP points. But you can also start looking at your diet in terms of, well, I'm from Northern Europe. I'm probably lactose tolerant, so dairy isn't really my big concern, except there's a few oligosaccharides in dairy too. But so maybe fructose and fiber is my big problem. And somebody else might have a big problem with fructose, but they said, fiber, certain types of fiber are not that bad. I've been using some and I'm okay. So you can tease it apart, but only once your symptoms are better.
Gotcha.
That's what I think.
Yeah. So it doesn't. The bacteria are, in your opinion, robust enough to where going on a lower carbohydrate diet is perfectly healthy for a longer duration until your symptoms get under control, right?
I do. I think so. You do. First of all, think ancestral. I think that's really helpful to just, what we didn't, fruits weren't as sweet back then, so we didn't eat, we had to forage more, intermittent fasting, and all of that. I think those are really good, but maybe treat the diet as kind of a proof of principle. If I can go in this, aggressive diet and I can get completely better, then even if 6 months from now I'm on vacation and I have symptoms again, I know that when I get back on Monday, I can buckle down. That's what's really important in the long term. Not that you'll never, ever have a symptom again.
Exactly. And that's good from a mental perspective as well. When you do something like that, you can maintain consistency with, like a diet that's going to last for the long term, and you get results. It's just that peace of mind, like you said, knowing that, if you want to get your symptoms back under control, you totally can too. So that's why it's so good. I guess anything else besides, a lower carbohydrate diet, and then eventually, if you get better, to add some more diversity. Is there anything else to build better health as far as the microbiome? And I guess for me the issue is it's like most of the time we hear that a diverse microbiota or microbiome is the healthiest, right? So if we're on a lower fermentation diet, what can we do to eventually get back to that, right? Because, yeah.
Again, I'm going to turn that question around a little bit.
Yeah.
We think when we're cutting back on these fermentable carbs, for instance, that's not so diverse. But first of all, it can be diverse. If you look at the Fast Start Diet mobile app, some 150 vegetables or something, over 50 are really low FP. And all these fresh herbs that you can have in your diet, they're all really low FP. So a diverse diet really isn't the big problem. But it's interesting you bring up diversity because people with irritable bowel syndrome, at least IBS-D, their at least their fecal microbiota is less diverse.
Yeah.
And when you restrict fermentable carbohydrates, diversity increases, not decreases.
Wow. Okay.
And that's also shown not only for just restricting the fermentable carbs with diet, but also in a study by Marlene Riemele out of Austria, excellent study on fasting, showed that intermittent fasting increased diversity and really allowed the bacteria along the mucosal surface to thrive as well. Some very important strains of bacteria. So less might be more.
Yeah.
We're still looking at this, but
yeah. So it's a really good point. It may not just be that you need to eat every food under the sun. So any other tips for people with debilitating gut issues to help them kind of, I've kind of been there when I was sick. Let's say you're at a place where you can only eat a couple of foods and you're really having symptoms. Any tips for people like that?
Yeah, well, one of the things that I find when I work with people is a lot of people are kind of blaming some foods. And when I hear that, I think, why would that be the problem? Like I worked with one woman. I'm sorry, I wasn't working with her. I did an interview with her recently, and she said, "Well, one thing I can't have is tofu. It's just terrible for my IBS." And I just remember thinking, "Wow, tofu, super low carb, mostly protein, a little bit of fat. It's typically a very inert food for people with these conditions." But I think sometimes what happens, and this is what can lead to orthorexia. People are trying to be very healthy. They may have worked with people or read things over the years, and so they've started to eliminate foods along the way. I don't do nightshades. I don't do any GMO. I don't do anything soy. I don't, and then of course there's people that have other views too, like, well, fats are disgusting, and I can't eat meat. So I do work with vegetarians, so I'm kind of getting used to that issue and what are the strategies you can do in a plant-based diet. But here's the 2 points I wanted to bring up. I think that the wrong foods can get the blame for what's causing symptoms. And so people start eliminating things from the diet that weren't even the problem in the first place. And there's 2 reasons for that. One is foods we eat now are going to, if they are going to trigger symptoms, it's going to be sometime in the future.
Yeah.
And if you're lactose intolerant, if you drink a latte, you might have to rush home to get to the bathroom. And that's happened to me a couple times. It's very fast acting because lactose, if you don't digest it, your bacteria can break that down and produce gas from it very quickly. Look at the lactulose breath test, similar molecule. If you're consuming very complex fibers, those take a long time to break down. Bacteria, they're together producing thousands and thousands of different enzymes, but they have to collaboratively break down these complex fibers, and it can take a long time. So a lot of fiber that you ate may not really catch up to you for 12, 15 hours or more. And so meanwhile, when it finally does and you have symptoms, you blame the last thing you ate. That's one problem. Another problem is we tend to eat things in mixed meals. So a lot of people, look at pizza. Most people think, oh, pepperoni, it kills me, or tomato sauce, it just kills me.
Yeah.
And too much tomato sauce might kill you, but a little tomato sauce in the pepperoni is probably not the problem, but the wheat and the resistant starch in that pizza dough might be killing you.
Yeah.
So I think that you have to look at your diet through a lens, kind of a scientific lens of what's important and why. And then when I work with people, I say, okay, well, a few of the things you don't think you can eat right now, I'll go with it. You can't tolerate egg yolks. But do me a favor. 2 or 3 weeks from now, I want to challenge you to try that food.
Yeah. And that's awesome because I kind of make sure and talk about that too. The importance of, challenging your body sometimes, and I guess not going too crazy about like thinking about every food, right, that you put into your body, because it's really hard to tell, if one particular food is really affecting you or not. I think it can be kind of stressful to get in that state, right?
I agree.
Yeah. So
and when you don't know, you grasp at straws, but the trigger food diet, anecdotal, what to avoid, the list of fats and this and that, that's been just so debunked. There's literally studies saying fats do not cause the problem, do not cause reflux, for instance, but it's still in there. It's still common advice. But even the American Medical Association, in their training materials for continuing education to doctors, they've just thrown out diet completely as anything you can do, for instance, for chronic acid reflux, which is sad because they're throwing out the baby with the bathwater. But it speaks to just how poor these kind of trigger food diets were at controlling symptoms.
Definitely. So another question here. What do you think about the future of IBS and, research in the microbiome? We're at a point in time where people are becoming more aware of gut health and there's more research being done in this area. I just kind of am interested in your thoughts about, what are you excited for going forward? Any new understandings you think in the future, or new technologies or treatment methods, or just the way things are moving? What are you kind of,
Yeah. I mean, on the one hand, I'm loving it, because if you love science, there's so much food for thought there. Gobbling down these papers. But of course, the challenge is organizing and saving that information and kind of committing it to your mind so you can use it and put it into use. It's really challenging. One thing I worry about a little bit, I think we are, learning a lot more about the current state of the microbiome. We've known for a long time, it's impacted by diet and genetics and lifestyle and age and hygiene, all of that stuff. But as we tease that apart, it is great that we'll have more actionable information. But one of the things that's a little sad is I think when we're doing this research, one of the things we're going to learn is how badly we decimated this rainforest that we have. It's something that took all these millions of years to evolve, and we've just beat it up. But that will be our new normal, and we'll just have to deal with it. But I am really excited. I think some of the breakthroughs, a lot of them won't be in the form of a pill, but a couple might. I think this SIN-10 that Pimentel's group and others are working on, it's a statin-based medicine, non-absorbable, but it looks like it's going to be able to inhibit archaea and impact high methane levels, because it's a very challenging condition. If it's safe and effective, I think that could be potentially one of the stars in this area. And the idea is it's a cholesterol medicine, and these archaea have cholesterol molecules in the membranes, and that's just some science around it. But other than that, I do think that some of the science will highlight what some of the earlier researchers in the field, including Rob Wolf and Dr. Mike Eads, about the importance of our Paleolithic roots. And we talked about that a little bit, but how did people eat back then? If you couldn't find food all the time, well, there's your intermittent fasting. We had a much more diverse microbiome. So I think it's going to put a new spotlight on Paleolithic concepts and principles in diet, not only for GI issues, but even, just health, metabolic, cardiovascular health, longevity. Because I don't think we're smart enough to outthink millions of years of evolution just yet. So, there's a few things I think about there.
That's cool.
There's a lot of important emerging species to keep an eye on.
Yeah.
This Christensenella minuta, that is, it's one of the, most, diet is really the bigger effector of microbes in the gut.
Yeah.
But some are genetically determined. Twin studies showed this one particular organism was important, and it's also an important one for leanness. So that's interesting for Colibacterium prausnitzii. There's so many more. Bacteroides fragilis that I worked on is a huge player, along with its relative Bacteroides theta iota omicron. There's just so much going on. And, of course, how do we deal with too much Methane Gravibacter smithii, these archaea? And that brought up just one last point I wanted to make. You mentioned what else can people do about diet, and we're talking about being diligent and cutting these fermentable carbs. But you do need to be careful you don't go too far, especially with people that have constipation, because one study I read just recently was with anorexia. They found an increase in these methanogens and an increase in methane. And people with anorexia often will complain of constipation. And so it might be an adaptive response when you have extreme caloric deprivation, that your body and your microbes kind of adjust to that, because we know these archaea organisms, methanogens, they're very good at helping bacteria get calories out of these fermentable carbohydrates by being a sink for all the hydrogen. So it lets the bacteria kind of turn back on again. So it just I think it points to some dietary limits we need to be aware of, and we talked about orthorexia as well.
Yeah, wow, so fascinating, and I just think it's amazing, the complexity of our bodies and bacteria and everything. It's really cool, and I hope I'm excited for the future too, to learn more and for better understanding of this issue.
Sure.
Yeah.
And your articles are great, by the way. You're very good at distilling the facts. So I look forward to reading more of those.
Thanks. Yeah, I try and take as much of an evidence-based approach and base everything based on the studies as well. So
I noticed.
Yeah. So where can my audience, what is your website again, and where can they find your products and learn more about your work if they want to connect with you, get some help, or try the Fast Track Diet or any of those resources?
Sure. Well, they can certainly reach us at digestivehealthinstitute.org. That's a big hub for a lot of things. So you can find a free ebook on the diet if you want to read about the concept, but also our regular books, ebooks, print books. You can be linked there. The mobile app, you can get a real chance to talk about that, but a lot of people are downloading this. It has 1,000 foods in it and all these. It's where the rubber meets the road if you want to try the diet. The app is really a good choice.
Yeah.
People can also go to the Fast Tracked TRACT Diet official Facebook group. As I mentioned, 8,500 members, all talking about recipes and diet and strategies and science. And we have a bunch of admins on there, and I'm one of them. And we do our best to keep it science-based and very upbeat.
Yeah.
We're not a big site for complaining about it.
Yeah.
We're more of a site for let's act on it.
Yeah. That's awesome. Well, I really appreciate you sitting down and chat about this topic. I've learned a lot, and I think other people get learn a lot and get a lot of benefit from this. So really appreciate it, Norm. Thanks so much.
Thank you, Josh. I appreciate it.
Yeah.
So long.